Hi and welcome back to the channel. In this video, I'll be giving you a brief overview of Polycystic Ovarian Syndrome. So some background information on the condition. It is a condition with excess androgen production and ovaries which contain many immature follicles, and that excess androgen production can result in hyperandrogenism, such as the presence of facial hair on your face, also called hirsutism. 5 to 10% of premenopausal women are affected, and some of the main risk factors to be aware of are diabetes, obesity, and family history. And indeed, 70% of women presenting with polycystic ovary syndrome are obese women. Quick overview of the pathophysiology. Its exact pathophysiology is poorly understood. However, there are two main hormonal pathologies present in patients with polycystic ovary syndrome, and those are excess levels of LH and insulin resistance, and therefore increased level of insulin. So high levels of insulin result in the suppression of production of the sex hormone binding globulin in the liver, which normally is produced in order to bind to androgens present in the circulation to suppress their function, and that results in more free androgen in the circulation. However, high insulin also causes more androgen production to be stimulated in the adrenals and in the ovaries, further exacerbating this issue of hyperandrogenism. Additionally, you have high LH production, which means that more ovarian androgens are produced. However, really high levels of androgens can actually suppress the LH levels and therefore stop the LH surge, which is necessary for the ovulation. And as such, you can get follicles developing in the ovary but be unable to actually then be released, which is what causes multiple follicles to be present in each ovary. In terms of the clinical presentation, there's three main aspects I would like to discuss. Those are menstrual abnormalities, hyperandrogenetic issues, and some of the systemic features. So the main menstrual abnormalities patients will complain of are oligomenorrhea or amenorrhea, but there also might be some infertility and pelvic pain. So a patient might be come in complaining of the fact they've been trying for a baby for a year and the partner has undergone sperm count investigations and they came back all fine, and they're still unable to conceive. Some of the main hyperandrogenetic issues are acne, especially something called acne vulgaris, which you can see here, as well as hirsutism, which is this abnormal facial hair growth in a woman, and something called acanthosis nigricans, which is darkening of the armpit skin. And some may also experience male pattern hair loss. Lastly, some of the systemic features to be aware of are obesity and especially depression. So, in terms of investigation and diagnostic criteria, polycystic ovary syndrome is a diagnosis of exclusion, so a lot of tests need to be done before the diagnosis can be made. So you can test the serum progesterone levels, and if they're elevated, you would be suspecting adrenal hyperplasia, but again, those would be normal in someone with polycystic ovaries. Serum prolactin, if it's elevated, you'd be thinking more about prolactinoma, and if there's deviations in serum TSH, you'd be looking at thyroid issues rather than polycystic ovaries. The gold standard investigation in anyone who is suspecting of having polycystic ovary syndrome is a transvaginal ultrasound, and it would show multiple follicles in each ovary, as you can see here. The diagnostic criteria for polycystic ovary syndrome are oligo and or anovulation, polycystic ovaries seen on imaging, such as on the transvaginal ultrasound, and signs of hyperandrogenism, such as hirsutism, etc. And in order for this diagnosis to be made, 2 of the 3 Rotterdam criteria need to be present. The management is split into 2 categories, those who desire fertility and those who do not. So one management that is recommended to all women is weight loss and the use of metformin to control the insulin levels. However, clomiphene and or letrozole can be used in first line for those struggling with infertility. However, it that doesn't work, you can try gonadotropins such as folitropin. And if that doesn't work, you can go down the surgical route and try laparoscopic ovarian drilling. For those who do not desire fertility, again, you should recommend weight loss and on metformin to try and control the symptoms. However, first line recommendation for those who don't desire fertility is an oral contraceptive pill. If that doesn't work, you can try anti-androgens such as spironolactone or finasteride. And in both categories, you can also try topical cream called alpha-ornithine, which can help with the excess facial hair. This was a very brief overview of polycystic ovarian syndrome. If you have any questions, please leave them down in the comments. I hope you enjoyed this video. Please like and subscribe, and I hope to see you in the next one.